So, good morning, good afternoon, and good evening, depending on where you're arriving from. I think I have people from all over. Andrea is experiencing an evening right now because I just spoke a little while ago with her, and some of you are sort of in the eastern part of the uh, Western Hemisphere, and us here on the coast are just looking at a nice 10 o'clock in the morning. So I warmly welcome you no matter where you're from. And we really want to welcome you to this educational conversation that we're having on post-traumatic stress. And it's nice to see some new faces. I'm very happy about that. So we're going to be discussing the different use of PTS D and I. So there's an interest when it comes to post-traumatic stress injury and using that vocabulary, and post-traumatic stress disorder. And lots of students that we have through our trauma-informed course have asked questions around that. And some of the people that we work with, depending on where they've come from, clinical or more the therapy routes, discuss the impact of trauma in two different ways. So we thought, wouldn't it be a great day to be able to actually bring a bit more awareness to this? Hello, Maria, welcome. And to be able to actually have a conversation around it. So what I'd like to, yeah, thank you.
Glad to be here.
What we'd like to do is I would like to just invite you into a quick meditation before we get started in this conversation. And the reason that I do a quick meditation is because I really wanted to start accessing our parasympathetic nervous system. And the best way to do that, of course, is through our breath, because the ability to breathe allows our vagus nerve, which is the hugest part of the parasympathetic nervous system, to start relaxing. So let's take a few moments and just center ourselves here, and in a comfortable seated position, which I hope most of you are. I invite you to just gently close your eyes. And if you don't want to close your eyes, that's perfectly fine. I'm just giving you that invitation. And just to start taking some nice deep breaths in through your nostrils. And some nice exhales. And what we're doing there is we're really inviting in that oxygen. If you can hold it for a few moments, what that does is start toning the vagus nerve, relaxing the parasympathetic. And as you feel the weight of your body in your seat, maybe noticing your feet being firmly planted on the ground, maybe the space between the floor and the earth itself, I just want to invite you to let go of anything that may be distracting in this moment, to welcome in a bit more of the mindfulness that we're going to move forward with in this conversation, curiosity around what some of the meanings that words and language make for us and how we use them. I'm going to invite you to, as you're taking nice deep breaths, to think about being in this environment with other people of like mind, being able to share some of the knowledge that we're going to talk about today, and really the invitation to be curious, but also to contribute. Every time I come into doing a facilitation, I really hold it as an opportunity to be taught something new. So I hold most of the people that attend as teachers, those who contribute. So I'm going to invite you to do that. And as you're here, just bringing in these pleasant thoughts and invitations for curiosity and teaching, I just want you to also be able to recognize that light inside of us and to be able to share that with the class here today. So just also giving of yourself in a way that's sharing of knowledge in this training. Let's take another nice deep breath. As you take one more nice deep breath, I just openly invite you to this space where we are in the calm and relaxation. So thank you for coming together here today. Hopefully we'll be able to carry this knowledge with us throughout the day, and it will inform us differently. So we have people again from all over the world. I'm very grateful for that. That's the one thing that Zoom has given us now, this ability to actually access all kinds of people. And for me, I find that a beautiful way to bridge different ideas, different cultures, and different information. So that part I'm quite grateful for. So I'm sure as we share this conversation that we'll relate to it in one way or another. My name's Brad Hardie, for those of you who don't know me, and my business partner, Susan Hogarth, and I are principals of a company called Moving the Human Spirit. And we are the global leader in trauma-informed coaching and training. We generate positive conversations around mental health and evolving the coach lens. I always think it's a good place for us to be able to flex our coaching muscles, but also in the other avenue of mental health itself, it's really good to be able to have open conversations about the human condition. And I think that's what makes it so passionate for me. We create continuing facilitations in the ICF itself, which is the International Coaching Federation. We also do coach trauma-informed trainings for different organizations that hope to have a trauma-informed lens to be able to work with in policing, in organizations, in healthcare. So we just want to continue being active in these avenues and to be able to bring that trauma-informed lens and the human condition in our processes and to other individuals who most need it. We also actively work with families who have experienced trauma, post-traumatic stress being one of them, and different individuals who have also come through traumatic events, ACE scores, addictions, anxiety disorders. So we try to remain very active in the work that we do because we think that is the best way to gain knowledge moving forward in what it is. So today for our topic, again, we're going to be looking at post-traumatic stress disorder and post-traumatic stress injury and discussing those two. And we chose to do it as June is Post-Traumatic Stress Awareness Month. And again, the day that they will be acknowledging a lot of information is June 27th, which is the Awareness Day. So it's both a day they celebrate the recovery and resilience of people on the 27th, but we're bringing quite a bit of awareness through June in this particular space. And of course, that's really good for us trauma-informed coaches. So the best thing to do, I think, is just to start with the post-traumatic stress disorder. So if we start talking about the D, post-traumatic stress injury, so talking about the I. So let's look at both these terms are used quite interchangeably. So when you think about it, we either have clients that discuss post-traumatic stress disorder or post-traumatic stress injury, and they describe the psychological impact of traumatic events. So while both highlight the profound effect of trauma and its effect on individuals, there's this ongoing debate within the mental health community. And it's regarding the terminology and its implications. And that's really why we wanted to get together here today to have that discussion. So we'll have a short conversation that delves into the nuances of PTSD and PTSI. And we'll explore the definitions. We'll look at similarities and differences, and we'll just try to shed a little bit of light as a group on the evolving perspectives surrounding each of these. So I think it's important for us to start by defining them. When I think about post-traumatic stress disorder, which was first introduced into the Diagnostic and Statistical Manual of Mental Disorders, which is now referred to as the DSM-5. I don't think we've hit 6 yet. I know there's a lot of conversation around whether or not moving forward it will be used a lot. That's a different topic altogether. And I'm non-clinical, I don't diagnose. So for me, It's not a topic that I can speak heavily. Maybe at some point we'll have someone in that can. But it is a diagnostic tool that is used in clinical settings, and it's a mental health, determining a mental health condition or psychiatric disorder that may develop after a person experiences or witnesses a traumatic event. So within PTSD, it encompasses a range of symptoms, including intrusive memories, nightmares, flashbacks. We think about things such as hyperarousal, or in some cases, hypervigilance. Hypervigilance is when we feel constantly charged by our sympathetic nervous system, and we are basically on guard in what we refer to as the fear brain. We can also see other things as a result of PTSD in some people: avoidance behavior, negative changes in mood and cognition as well. So PTSD is diagnosed when these symptoms persist for usually more than a month. And the other thing that we look at is if they're significantly impairing the individual's day-to-day function. So those are some of the things that we look at when we're talking about the diagnostic of post-traumatic stress. Now, versus that, we also look at PTSI, and post-traumatic stress injury, on the other hand, is a term that has been coined by some mental health professionals to emphasize that the psychological consequences of trauma should be considered injuries rather than disorders. So I have spoken with several people in clinical side and in mental health, and there has long been a controversy between the D and the I, and it's dependent upon calling things disorders or referring to them as injuries. Pardon me. Post-traumatic stress injury is a term that emerged as an alternative to post-traumatic stress disorder. And it's really aiming to try to shift our focus from it being a disorder to an injury instead. So, and I can support some of that, because sometimes if we look at things as being a disorder, I understand where that comes from. We look at the body being in dis-ease. That's where we get the word dis-ease. So disorder, I can understand why they look towards using that terminology. So supporters of PTSI, post-traumatic stress injury, argue that the term injury itself shifts the focus from a stigmatizing label to a more accurate representation. And what they mean by that is that they are asking it to look at trauma's impact on individuals, and it better reflects the psychological impact of trauma, if you will, because of the external event, rather than implying that there is an inherent pathology with the individual themselves. So that makes total sense to me. So the distinction is quite important, as it encourages a much more compassionate, and in our work as trauma-informed coaches, one of the things we talk about is working in compassion. And we work in compassion because we feel that it is the love child of empathy and action, if you will. So compassion is where we state, I have a feeling of understanding of what's going on, and I'm willing to help. So that, of course, in trauma-informed coaching is a huge thing for us. But it also destigmatizes the approach to individuals experiencing trauma-related symptoms. And I think that that's quite important. So when we think about being able to actually redefine that traumatic experience, one of the key distinctions between PTSD and PTSI lies in the interpretation of the traumatic experience itself. So again, while PTSD and PTSI share many similar instances or similar symptoms, the primary difference lies in the conceptualization of trauma and how we organize it moving forward. When PTSD centers around the concept of the traumatic event and refers again to that psychological response to the traumatic event. And PTSD or PTSI, I'll get caught up on these, I should say them, the injury piece of it, acknowledges that the trauma can result from cumulative exposure to stressors over extended periods of time, and emphasizes more the psychological injury caused by the trauma itself. So it's interesting. The broader definition, of course, encompasses this experience of individuals who may have encountered single, discrete traumatic events, but have also been exposed to what we would refer to as chronic stress. Things we think about, such as military personnel, first responders, police, healthcare workers, or victims of what we would call long-term abuse. So very interesting. Another important distinction that arises for us is the connotation around the term. Again, the word disorder in post-traumatic stress implies something that is long-term, chronic condition, whereas when we think about injury, we are discussing something that it sort of conveys that potential for recovery and healing. In the work that we do, of course, we're always interested in that potential of recovery and healing versus looking at something as if it may not be resolved. I can remember in some of my early days of trauma-informed coaching, some of the clients that I worked with would come to me and say, I'll never recover from post-traumatic stress disorder. And I think that that has been a huge shift over the last 10 years that I've worked in this area. And people understand now that there is a imprint, a traumatic imprint, but the ability to be able to recover, we can't dislodge the memory itself. Coaches, as trauma-informed coaches, we don't work in the past. That is a clinical therapeutic realm. That's not how we work. We work in the here and now. But as a result of that, being able to move people with an understanding of making sense of the story, honoring the story, but not having to dive into it and work specifically in it, but growing forward our future memories, if you will. So I always like that ability to think about it as a recovery or potential for healing. Not that we do that as coaches, our clients do, but I would still rather be working toward that potential than feeling like this is something that I'm going to experience for the rest of my life. So the word PTSI, the post-traumatic stress injury, really aims to promote that more optimistic outlook and emphasizes much more the resilience and the possibility of growth in the aftermath of the traumatic event. And what is the work that we do if not looking to be more optimistic in what we're up to? So advocates, of course, using the post-traumatic stress injury argue that it underscores the extreme nature of the trauma. And of course, as a result of that, also reduces self-blame. It encourages individuals to view their symptoms as a natural response to an injury rather than a personal failing, which is quite interesting. In our work, we do that quite a bit. It's that this is a natural response by the body. The organism has one job, and that's to keep us alive. And as a result of that, what does it do? It puts us into the sympathetic nervous system. That's what our body was built to do. Everything that our body does has a positive intention behind it, even if in the moment itself, it doesn't feel like it. Because we can have reactions at moments where it's like we would rather suppress how we react than actually experience it. But to be able to understand that the body is doing exactly what it's supposed to be is quite a relief. Certainly when I look at any of the experiences that I've gone through, it's wonderful to know that my body's working the way it should and that I'm not broken. I don't need to be fixed. So again, we're looking at this language to describe mental health conditions that can shape societal perceptions. And that's really what I think we have an opportunity to look at here. You know, what's our perception and influence, and how does it help, or what behaviors of the individuals are being looked at? So I often think about a student saying at one point, you know, if I have a broken leg, does that mean I myself am a broken leg? It's more looking at this is an injury that has happened, and that doesn't mean I'm a broken leg. It just means I have a broken leg. So understanding that as opposed to possibly a diagnosis. And again, I'll also underscore the idea around a diagnosis. I think it's a huge benefit for us to be able to have the DSM-5 in order to make a diagnosis, because sometimes if the body lives in hypervigilance for too long, we run a lot of the opportunity for organ damage, and we want to be able to have something that will regulate the body so that we can then move into things such as talk therapy, coaching, or any other modalities that work with cognitive distortions or ideology around the limbic system, the thalamus, and how we evolve emotionally, knowing that we are based on visual, auditory, kinesthetic, olfactory, and gustatory, which makes up our entire system as a human and our experience of life. So the debate and the controversy around it, the introduction of post-traumatic stress injury has sparked a very lively debate, of course, in the mental health community. Some professionals argue that changing the terminology may have unintended consequences, potentially leading to confusion, inconsistency in diagnosing and treating trauma-related conditions. They also express concerns about what happens when we start medicalizing normal reactions to trauma and the potential of over pathologizing, which is when we take something and say it's a pathology, when we look at it from medical terms and say it's a disorder. What we must do is medicate it, as opposed to look at it as a natural reaction from the body. So it's a very interesting thing. So in mental health, of course, what we want to do in terms of this use is to not be over diagnosing certain situations. I talked to a gentleman who is the head of UVic, University of Victoria, and he runs the psych department there. And he was saying that at some level, there's almost 400 specific symptoms for diagnosing post-traumatic stress disorder itself. So that's quite interesting to me. Again, I'm not from the clinical realm, but I thought, isn't it interesting that it gets encapsulated into so many things? So not being able to overdiagnose, also understanding that it's an injury, can be quite helpful. And again, from a societal point of view, I think that is a useful thing to think about. On the other hand, with post-traumatic stress injury, the content that the shift in terminology really, again, fosters that much more compassionate and supportive approach to trauma survivors. And it highlights the injury aspect of it, which I think they argue is it validates and normalizes the psychological struggles experienced by individuals, while it does reduce the stigma associated with mental health conditions. So let's see where we're at. Oh, geez, I'm over talking. Sorry, I get carried away with this stuff. I want to leave us some time to talk with one another. So when we think about moving into the treatment and recovery, when we're talking about regarding treatment and recovery, the approaches to post-traumatic stress disorder and post-traumatic stress injury are generally very similar. Both conditions can effectively be addressed by evidence-based therapies such as cognitive behavioral therapy, eye movement desensitization and reprocessing, medication when necessary. And again, I'm stating that the medication fact because sometimes we witness the body going into hypervigilance and staying there for extreme periods of time. And we know that in that state, what happens is organs, I'm reiterating this, organs become damaged because the blood flow is taken away from usual use in a parasympathetic and pushed out in a sympathetic to contract muscles, push blood into areas that need it. The heart will race faster, the lungs will take in more oxygen. And as a result of that, of course, it shuts down some of the other organs, the liver, the spleen, the kidneys, the bowel. So if we're in that state too long, the body is not operating the way that it should. But the primary goal, of course, is to alleviate symptoms, improve functioning in our social settings, and promote overall well-being when it comes to PTSI, PTSD, depending on which one. The objectives at the end are always the same. And that's for us to make sure that the organism survives and that the human condition doesn't get confused. So understanding these nuances within PTSD and PTSI has broader implications for us in society. Recognizing trauma as an injury rather than a disorder, again, helps us foster a more positive outlook. So I think the debate surrounding it and raising important questions around the language and how we use it, understanding how we address trauma, and thinking about it, I think about it personally as part of the human experience on some levels. We don't all have a sunshiny Facebook day every day of the week. So it's interesting how we look at it. We shift towards holding promise and promoting empathy and understanding when it comes to these things, not only post-traumatic stress disorder, post-traumatic stress injury, but also any mental health concerns that we go through so that we can ensure a comprehensive understanding. And of course, we know once we have understanding and awareness, that's where healing and nurturing promotes a better health and life for the people that are involved. So in conclusion, I guess what we can say is that even though these two are interchangeable, I hear them used often by the same person that is diagnosed or calls it an injury. The distinction between them are essential for our insights and understanding. So I think what I'll do is just invite any comments or questions now. You've all been so patient for me to talk. So what are your thoughts on this specific piece of information?
Brad, just real quick, do you mind just touching on trauma-informed? I'd like to hear your definition about it.
Trauma-informed, for us, trauma-informed in a coaching sense is when we can move into holding our ethical guidelines and principles, core competencies, and work with people in a session where we recognize the imprint of trauma when it comes up, and then being able to have the skills and tools to be able to move forward in the session within our constructed contract, and to stay within the ICF, International Coaching Federation guidelines. So for us, when I think about trauma-informed training, it's very much similar. It's about us being able to recognize the imprint of trauma, to be able to recognize the cognitive, psychological, physical, and behavioral aspects of trauma, and to then be able to work with the client within that to assist them in numerous things such as grounding, forward focus, solution focus technology, or modalities, I should say. So that's basically how we look at trauma-informed, understanding, being aware of it, knowing how to work with it with confidence, and being able to assist the client in executing a more desirable future for themselves based on the imprint or the moral injury that occurs.
So in general, I'm sorry, I know we're not, or my questions aren't with what you just covered. I'm just trying to wrap my mind around
No problem.
that with this. So with trauma-informed, my understanding just in general is it's an awareness within somebody else, not within oneself. Is that correct?
Well, I personally think that you can't have awareness within someone else unless you have it within yourself. So I have found a lot of people that go through our coursework, no matter if it's trauma-informed coaching or trauma-informed training, a lot of the work is based in self-awareness. And as a result of that, being able to regulate our nervous system, because we also acknowledge that there's no regulation without co-regulation. So if I'm, for instance, if I'm a trauma professional working with a client, I have to be able to regulate myself before I can help regulate my client. So yes, it is within self and being able to recognizing it with others as well. Is that helpful, Daniel?
It was, and I'll save. I have lots of questions, but
Okay,
I'll
well, you can hang out because
I'll let the
I'm
rest
here all week.
That's great.
Andy, go ahead. Maybe Andy wants to speak a bit to it as well.
If you don't mind, I'd
Please,
love
by
to.
all means.
Having recently come through the certified trauma-informed coaching program, one of the things that I really recognized personally is that our global society is almost so dependent on people continuing in an unregulated state that when you're going through trauma-informed trainings and learning more about regulation and how to process through trauma, it actually also gives you a lot of skills to recognize some of your own experiences as well, but in a process that is healthier and because you're learning these skills and tools that you would be using with other people. And I personally found myself using the tools in my own day-to-day life, personally with family. When you're able to take a trauma-informed perspective, it isn't just about working with a client. It does truly permeate the way you look at things and the way you approach things in a very beautiful way.
What Andy said. Yeah, beautiful.
So what I'm hearing is, incidentally, you become aware, but intentionally, trauma-informed education is not typical for self, it's for someone else.
Well,
So when somebody uses that language of trauma-informed in a classroom, it's typically not for the nurse or for the firefighter, it's for the people that they may experience while they're in the job. Is that correct?
Yeah, Andy, I'll let you answer for yourself.
Oh, yes, I do. From this program too, I do trauma-informed trainings. Actually, I did one recently for real estate agents because they are in a unique position to affect massive amounts of security for people's housing if they are not careful of their language, how they approach people, and even their own internal monologues when it comes to discriminatory practices. So when I was teaching a class on trauma-informed perspectives, it was for them to be able to take some of the tools and use it in their day-to-day life. It wasn't about me sharing my personal experience.
Beautiful. Thank you, Andy. And yeah, I just want to speak a bit more to that. People come to us to become trauma-informed trained, Daniel, and what inevitably usually happens is they'll walk away with a bit more. They'll walk away with the ability to use it for their clients, but it has been rare that they haven't walked away saying, oh, wow, I signed up for this for one reason, and I'm actually walking away with this whole other thing for myself as well. So it's an and, I guess, if you were, instead of an or.
That was great. Thank you very much. And then if I'll tie it back in just so I don't feel terrible asking those questions.
Don't feel terrible. It's not worth it.
For the PTSI, very fascinating. I've just finished years of research within PTSD, and not once did I ever see anything with PTSI, and I love it already. So thank you for that.
Beautiful. Thank you, Daniel. Well, I think it's a great conversation for us all to have. Again, I recognize both the diagnostic piece of it and also the social language around the word injury. So it's interesting, right? It's good, just knowledge for us to think about. Yeah, Andy.
So a question for me is being mindful of our scope as coaches, that we're not diagnosticians. when we're talking about post-traumatic stress, is this something where it should be client-led, that if they call it PTSD, we go with that? If it's PTSI, we go with that? Or do we just simply stick with post-traumatic stress because that could be all-encompassing? What would be a recommendation on that?
Yeah. How I usually use it is that the reason that we talk about both of them is it's the same as the reason we would talk about the window of tolerance in the polyvagal theory. Some clients will come from the clinical setting where they will refer to what their imprint is as more of a post-traumatic stress disorder. And then we'll have other sets of, and they may very well be the ones, I usually see them also being the ones that discuss the window of tolerance, because it's a clinical setting and that's usually what is used. The newest theory by Dr. Porges, when I'm talking to someone that may have been doing more self-discovery or a more therapeutic approach to their trauma imprints, they're more likely to talk about PTSI injury, and also refer to, say, I'm using this as an example, they may very well be referring much more to the polyvagal theory, because there's a huger social construct or content to the polyvagal theory. Again, pardon the pun, in theory, and injury relates to that, I find much better. But it also speaks to the fact that clinicians have been using Dan Siegel's work for years to explain to clients. So it happens if someone has been diagnosed, then they'll usually think about it in that route. I, like you, prefer to let the client lead the conversation on it. I find lately I've been putting language to it by saying PTS, and not putting the I or the D on the end, and allowing the client then to make that determination for themselves. Because again, as a coach, I don't diagnose, I don't lead, I don't want to inform them, but I do listen for how they're using it. Some people don't use either the I or the D. They just leave it at post-traumatic stress. Yeah, so I like that. Thanks, Andy, for that question. So yeah, client-led. What is their experience? Where are they coming from? Are they coming from a therapeutic background that uses one, or a clinical background that uses another? So yeah, nice awareness. Any other questions that we may untangle, dissolve, or input ideas? It doesn't have to be a question. Any comments? Yeah, Jean.
Yes, I'm curious where I can make a guess, but there's certainly a lot of work out now on developmental trauma and how it differs from shock trauma. Could you speak to that?
Well, I think, here's my take on it. These are just beliefs, which means nothing. So it's no truth. But when I look at it, I think that the great thing about the human condition is that we constantly love to label and change. And we do that so that we can have something new and fresh. When I think about some of developmental traumas, I often refer back to the three, acute, chronic, complex trauma, because when I look at those, I can think about them in a developmental stage. If I were to say, well, someone might talk about developmental trauma and be referring to the ACE score and say, maybe that's part of how the development happens and where I'm at in this moment. Because when we look at things such as complex traumas, that's often where we see PTS show up. And that also invites in the conversation around what are the ACE scores of the people that we're serving. So there's tons of nuances. So I don't know if I can directly answer your question, but I think that it has some legitimate conversation to connect back to these three areas that we talk about, like instead of the acute, which is the most immediate, like accidents, events happening, those one-time experiences, and thinking more about developmental trauma moving into a space of complex or chronic. So it's kind of like a melting pot, if you will, a little bit, I think. May I ask, when you think about it, are there anything specific that comes to mind for you within the developmental trauma, like any points that stand out and you say, well, I could reference it one to the other in that manner?
Well, what struck me when I read Dr. Heller's book called Healing Developmental Trauma was that there are some distinctions in how to offer support to a person who has that kind of trauma versus, say, a shock trauma.
Got you.
Yeah, so that seemed to be an important piece to understand.
Mhm.
And I guess what I've taken out of it and I use, because just about every client seems to have some kind of trauma I need to address,
Yeah.
is just go straight to supporting them, improving their internal sense of safety, because that's the foundation for the mindful brain and anything else. But anyway, I just wanted to throw that out and see
Yeah, I
what
love that. Yeah. Yeah, it's interesting because when we think about trauma work that we do, I'll often say options equal control equals safety. Control equals safety for everyone. How do we gain control? In our work, we do it through core values, belief systems, and really getting foundational work done first. And what I think about values and belief systems is that anytime a person's very sure about those, because what happens in our belief system from a traumatic imprint is that we think we've lost touch with ourselves and we have no control over our body. And that's a very unsafe place to be. So foundations and foundational work around values and beliefs is the anchor, or the shore, if you will, for the boat that's floating in the ocean. And anytime they have to be sure again or build confidence, we come back to value and belief. We are sure-footed in that. And then the confidence gets built to move forward in that work, i.e. they feel more in control, i.e. equals safety. And really what we're always doing is sorting for safety no matter what's happening. So yeah, cool, nice. So that's a cool, that I can look at that and say, that's a cool place for us to make that connection. Good. Thanks, Jean. Any other questions or comments or just insights? Beautiful. Please reach out if any other questions come up for you. I want to thank you all for taking your time to be here and allowing us to record it. And please carry on doing good work and keeping well all yourselves, and enjoy your weekend. And hopefully we'll have another educational piece. We're working on the big T, little t conversation, which I think might be quite interesting. So we hear that a lot in trauma, whether it was a big T or a little t. And I think it's almost like PTSI and PTSD. Maybe we have to have some conversation around it to see, what does that mean? So thanks everyone for being here. Take care, and we will see you again soon, hopefully. Bye. Thanks, Brandy.
Thanks, Brad. Appreciate it.
No worries, Daniel. Thanks for coming.